Top Med Talk.
Hello, I'm Joff Lacey and welcome to Top Med Talk and our series of podcasts from EBPOM 2019 here at the British Museum. We're just coming towards the end of the lunchtime break at the moment, but we've been able to grab another eminent guest to have a chat with us here on the Top Med Talk couch. I'm joined as always by Desiree Chappell. Welcome, Desiree, back again.
Hello, Joff. Thank you.
But also our guest this afternoon is Dr. Daniel Conway. Daniel is a consultant anaesthetist and critical care physician at Manchester University Foundation Trust. He's also the clinical director for the Perioperative Medicine programme there and visiting professor at the Manchester Metropolitan University. So, Daniel, thanks very much for joining us.
It's a pleasure, Joff.
Now, we've grabbed you so that we can talk to you about an initiative that you've set up in Manchester called ERAS Plus, but more specifically about the surgical school that you've created as part of that programme. Maybe if you could start by telling us about ERAS Plus, and then we can talk more about the school.
Yeah, will do, Joff. So, to start with, we established, and I was heavily involved in creating and running the ERAS programme as part of the Strategic Health Authority's remit at the time. But we came to realise quite soon that some of the really high-risk patients having major pancreatic surgery, liver surgery, upper GI surgery, weren't really being very well served by standard ERAS programs, and in particular we were very concerned about our post-op pulmonary complication rates, which when we looked at them were within the internationally expected standard, but it was still about 20%, which we felt was too high. So we decided to create a program that we called ERAS Plus that really tried to target those high-risk surgical patients. And so ERAS Plus involved an element of prehabilitation, a respiratory care bundle, and also a better way of delivering information to patients and their relatives about what was about to happen to them. And part of that information delivery included surgery school. So we established surgery school, which is really a patient information event that we run on a weekly basis, and it's proved wildly popular.
And is it mandatory as such, or an invitation, or how does it work when you've located or you've highlighted a patient that fits into that particularly high risk category? What's the process involved?
So everybody gets an invitation who fits into certain categories of being identified as high risk, and effectively it's most abdominal or thoracic surgery patients who know they're going to be going to HDU post-operatively. They're often booked via a number of means, either through clinical nurse specialists who will encourage the patient to come to surgery school, or via our CPET clinic. So when they've got a CPET appointment, they get invited to surgery school at the same time. I have to pay tribute to some of the great people that I work with, particularly our admin staff. So our admin staff will chase people up. They keep a register. They know who's coming, who's not coming. And most of the people want to come.
Yeah.
You know, they really want... it's a big event for somebody to have that kind of surgery, and they want as much information as they can get. And the ones who don't turn up usually have another appointment,
right?
And that's the main reason they're unable to come.
And so, is it one day, or how does the program work? And also, what do you actually teach them? Because you've got a mix of surgical procedures in there. So, how do you manage that?
I mean, that's probably the first thing I say to people is, you're about to you're here because you or one of your loved ones is about to have surgery, and just check that that's actually true, and there's not someone going to sit through the next hour wondering what this is all about.
I was meant to be in there.
Yeah. And then the second thing I say to people is, you know what, you're all having different types of surgery, and I'm not here to talk about the nitty-gritty of exactly what your surgery involves, but whatever surgery you have, it's a big stress on your body. That's why you're here today. We know it's going to be a big stress on your body, and what we're here to do is help you prepare yourself to deal with that stress on your body. So I set that out right from the start, that it doesn't really matter what surgery it is, you're going to take a hit, but you can prepare for it.
And then what are the main kind of, I suppose, categories of discussions that you go through in terms of trying to prepare them best for that?
Yeah. So we've focused on, if you like, 4 key areas, which we've heard a lot about in the Prehab conference this week. So we talk about activity, we talk about nutrition, we talk about the support of friends and family and within that is that kind of psychological support, but also the support that we as healthcare professionals can give people. And then we actually have an extra category because of the pulmonary complication respiratory care bundle. We talk about breathing and chest health, if you like, as well. So we have sort of 4 key areas that we talk about, but 3 of them are the sort of classic triad that we've been hearing about of prehabilitation.
Now, I was going to ask a question about the school. I know that there were some programs that I talked to a couple of people at last EBPOM, national programs that were bringing patients back in to teach new patients. Is that any part of the program that you're doing or looking at doing that?
So we haven't done that. So the people who are delivering surgery school at the moment are all healthcare professionals. So we have usually a doctor, which is often me, but a doctor, a physiotherapist and a nurse, and sometimes we have a pharmacist as well, which is really helpful. In terms of getting another patient back in, I think that would be a great idea. We do have some videos of patients talking about their experiences, and we signpost people to those YouTube videos. I think it would be possible to do that, and it's something we could look into. I mean, already the surgery school lasts about 40 minutes, 45 minutes.
That's short.
Which
really?
is relatively short, but then they get a tour of the critical care areas as well, and some of the ward areas, so they kind of get a look and feel of what they're about to see and what's going to happen to them. So it's probably an hour of lecture and then or talking with them and answering questions, and then about a 15-20 minute of tour. Yeah. And I think longer than that, I think people would find it hard to concentrate. Certainly, I do.
And I have interest, so how many patients have you been able to get through the school so far, and when did you start? Just to give us an idea.
We started in 2014. We average probably between 5 and 10 patients a week. And so we're sort of well over 1,000, we're probably close to 2,000. Our whole ERAS Plus program, because for a variety of reasons not everybody was coming to surgery school initially, has probably gone through 4,000 patients.
Wow.
Yeah, so we've got a lot of experience of doing it. And
I was going to ask you, so it sounds like it's so positive for the higher risk patients. Do you think this will actually go and you can revert it back to your entire surgical patient population?
Yeah, I think you'd probably need to modify it a little bit, because probably the risks of the complications that we're talking to people about is probably less, and so you don't want to necessarily frighten people. Obviously, you have things. I don't know if you've heard of joint school. Yeah,
that's what I was going to say. I mean, we do that in the U.S. a lot for joints and hearts.
Yeah, so there's already a joint school program, but I guess that's a little bit different in that. From what I can see, it's physio, it's therapy led. So it's physio and maybe an occupational therapist. Whereas the surgery school, because it's a bigger encounter that the patients are having, it's more multidisciplinary. But I think
ideally it would be all patients. I can't see a detriment, and I think, as you say, most patients, even if they're considered lower risk but having major surgery, are desperate for information.
I was going to say, it's an engagement thing. It's more of like they feel like they have contact with a person. We heard about that in some of the prehab stuff, and part of the benefit of doing the prehab and working with those teams is that it's the personal experience that they have before they actually even get to the OR. So I don't know.
Yeah, I think
it's
you could probably do it in a more but I think because it's maybe lower risk surgery, you could do it in a more cost effective way, because it could be like it could be a nurse and a therapist. You don't need to have someone like me in the room talking about pulmonary complications for people who are quite low risk of them.
One of the hospitals that I've talked to in the U.S., actually several, they have patient led prehab surgery meetings or surgery school, and so it's actually all led by ex-patients who just really want to be involved and saw the benefit of enhanced recovery.
Yeah, give them the information they think is relevant for them without probably the medicalization of it.
Yeah, and I mean, you can tell the pertinent points that you have to hit, and have a nurse or even not even a nurse, a medical assistant or whatever, go over those kind of things. But again, it's reaching those patients and giving them a touch before they actually get to the hospital. But it's wonderful what you guys are doing with the high-risk patients.
And so do you have feedback from those patients about how their experience has been with the school, and maybe how it impacted them after the operation?
Yeah, so Yeah, we've done that in two ways. Obviously, anecdotally, it's really interesting. You can, as somebody who's working in post-operative care environments, you can really tell the people who've been to the surgery school, read the materials, really engage with it, because they're keen to mobilise. We use incentive spirometers, but they really know what they're doing with the incentive spirometers, and they know what their baseline was and where they want to get to. So you can really tell the difference between those who've been to surgery school and those who just either slip through the system or even worse come through as sort of urgent cases without really being prepared at all. As far as sort of more formal feedback goes, we've been doing some patient experience surveys, and it is really positive. It's really positive. I think the thing that comes across again and again is how confident people feel, and it's really giving people that, overcoming anxiety and giving people the confidence. And that's for a variety of reasons. They get to meet these people and see how they're going to be looked after, which is a positive thing. They also realise they're not alone because they're in a room full of people who are just like them. And then when they visit the critical care areas, they see these people and think, well, they seem to be coping, so should I. So I think you get this confidence. I would say that surgery school alone, I don't think it's enough to initiate a significant behavioural change in something like activity. I think it's a big ask to do that for people. But it probably has helped with something like the breathing exercises, and I think that's been shown before, that patients are sort of more readily accepting of something like breathing exercises.
Do you think it sounds just like a lot of what we do with change management is managing expectations? Because, that's what you're really doing for these patients. You're just managing so they know, what to expect afterwards. And so you feel that confidence that, this incentive spirometer is going to hurt, whenever I do it, but I have to do it for that. So it sounds like that's kind of what the...
for example, with the incentive spirometer, because they'll have been using it beforehand, and say, for argument's sake, if it's one with the balls, they'll know, I can get 2 balls up.
Yeah.
And we've said to people in surgery school, your breathing's not going to be as good after surgery for all these reasons. And then, of course, what we said was true when they try and use it again. So it actually reinforces the message. The action reinforces the message, and of course we've said to them, but it will get better. You just have to keep trying. So they're not disheartened. Yeah. They're like, you said this would happen, but I'm gonna get back to where I was. So it works. It works well.
I just have one more question for you, Danny. Joff asked about the patient feedback. What is the family and caregiver feedback that you've gotten from this?
I think often certainly in critical care, the anxiety on family members has been shown to be greater than it is on the patients quite often. And I think you can't underestimate the anxiety of the families, and I think that they need to be supported. And also they need information, because you've got to get that right relationship, particularly between the nursing staff and the families, certainly in critical care, and I think on general wards as well, because the families will be ringing and, the nurses are trying to get on with their job. And I think if they have an understanding, again, of the expectations about visiting, about don't worry, we'll call you, all these things, then I think that can help allay their anxiety. And the fact that they know that their loved one is going to be really, really well looked after by a cohesive team who are committed to them, I think that makes a massive difference. And we've got a great team. We're really lucky. We've got a great team. But I think people can see that once they experience it, and I think that's really helpful.
And I just have one final question as well, more on the practical side. So people listening who think, that's a great idea, I want to set this up in my own institution. Tell us, can you give them a bit of advice and tell us any particular challenges you had in implementing this idea?
Well, we've had loads of people teams come to visit us, and just yesterday I was talking to a team from Cambridge who'd come to visit us, and they're setting up their surgery school, and it's starting in the next couple of weeks. They've got the funding, they've got the people there. So it's definitely doable. I can tell you it's really enjoyable as a clinician to deliver something like surgery school. It's a very positive experience, you really feel like you're helping people. And but it's a team thing as well. So I think if you were thinking of doing it, come and visit us or somewhere else that's doing it, but come as a team and think about how we're going to deliver this as a team, rather than one individual saying, I think I'll start a surgery school. I think the barriers aren't that great. I think to be honest, it seems like such a good idea that management don't particularly push back that hard against it. Obviously, the only cost is the time of the individuals involved, and so there will be an element of cost with that. But we had an MSc student look into it, and it's probably about between £40 and £50 per patient per session, and we have just started to code for that, so that we probably will be able to get some
funding for it.
to get some funding through the CCGs. So
hopefully,
I think it's done. Yeah.
Right.
Well, look, Daniel, thanks very much for your time. Excellent initiative. So
it's great,
congratulations
Joff.
with that.
Yeah, congratulations.
And thanks for listening, and we'll be back again very soon. All the best.
Top Med Talk.
Nick Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com, and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.